So good evening. My name is Josh Goodwin. I'm the physician at Regenexx Las Vegas. We're going to talk about regenerative interventional orthopedics and how this may be an alternative to orthopedic surgery. Just kind of a brief outline before we get into it. Just going to spend some time introducing myself, what Regenexx is, an idea about just the natural healing cascades and why we may want to utilize some of the procedures that we use for orthopedic conditions, how we determine who's a candidate, like what's the process for determining if these are a great option for patients. And then at the end, there will be some question and answer time. Throughout the webinar, you guys can type in your questions in the chat section if you would like, and then I'll get to them at the end. Probably won't stop in the chat or during the webinar until the end to answer the questions unless it pertains to what I'm talking about in that moment. We try to find time to do these so we can educate people on alternatives to surgery or other types of interventions for orthopedic problems if they're not working. Again, we're going to try to cover some of those things. Specifically, we're going to be talking about the use of PRP and bone marrow concentrate for orthopedic conditions. If you don't know what those are, we'll get into it, so just stay tuned. A little bit about my background. I am a medical doctor. I'm board certified in physical medicine and rehabilitation. I am fellowship trained in sports medicine and interventional spine. In my fellowship, I did participate in research utilizing bone marrow concentrate, which contains stem cells for low back disc degeneration. I've been with Regenexx for 9 years. I've probably performed closer to 4,000 procedures, and I'm a co-author on an article discussing a review on the different options for treating low back pain related to disc degeneration. So as I mentioned a couple times, a lot of the stuff that we focus on is orthopedic based. So that basically pertains to muscle, tendons, bones, spinal elements. And as you can see, these conditions really affect people of all ages. We see people of all ages. Now, the underlying cause may be a little bit different in the different age groups, but we've seen young patients and old patients for different causes of orthopedic pain. And there is a significant economic burden on trying to care for these types of conditions. So osteoarthritis, muscle tendon tears, back pain, neck pain, disc degeneration, pinched nerves. All of these things afflict many people and cost a lot. And many of us are familiar with the current treatment options, different medications that are prescribed, which we'll discuss can have their own set of risks. Different injectable treatments such as cortisone, again, can be helpful for pain, but comes at a cost. Physical therapy, bracing, other surgical options. As I mentioned, our goal is to try to help be that bridge before the progression to needing surgery. And so we're trying to help prevent that progression and that exposure to the risk of surgery. But even simple things like taking an ibuprofen carries risk. And so the class of medications is called nonsteroidal anti-inflammatories. These include your ibuprofen, Aleve, and prescription-based medications like Celebrex, meloxicam, diclofenac. You could probably read or see that they do have black box warnings on them for different complications, including cardiovascular risks like stroke and heart attacks, kidney risk, stomach ulcers and stomach bleeding, allergy. So while we prescribe these, and they are prescribed very often, they do carry significant risk with prolonged overuse which a lot of people can sometimes get into that pattern when they're dealing with an orthopedic condition that's not getting better. We've also learned there's some studies I don't have in here that have showed that chronic use of non-steroidal anti-inflammatories actually lead to more joint pain the more you use them. So something to consider. Many of us have to progress on or are injected with cortisone type medications. Now, these are just strong anti-inflammatories. They can improve pain and inflammation, but they come at a cost, right? There's a reason why your physician will only inject them 3 times a year, because the more you're exposed to them, the higher the rate of complications. And some of these complications include increased blood sugar if you're diabetic, weight gain, anxiety. And the big thing is that they're toxic to your tissue. So there's many studies showing progression of cartilage loss in joints that are injected repeatedly with corticosteroids. So it can lead to accelerated osteoarthritis progression, weakening of the bone around really throughout your body, osteonecrosis, which is bone death, and just rapid joint destruction. And so there are studies that have looked at that in regards to injecting steroids into joints or other tissues, showing increased rate of knee replacements for people that get steroid injections. So you'll learn that our philosophy here is joint and tissue preservation. So the tissues that you were given, we want to help maintain and preserve those tissues. And so we want to try to avoid things that destroy them, whether that be medications or corticosteroid injections, or if we can, not get tissues cut out, if it's the right choice. Sometimes people do need surgery, but our goal is to help preserve the tissue and try to improve its function. Obviously, surgeries come at cost as well. They're more invasive. Anything that's more invasive has more risk. And so, for example, spinal fusions for patients with low back disc or joint degeneration come at a significant complication rate. So upwards of 30% of people can have complications. If you're looking at major complications, and 30 or up to 60 of minor complications, to include all of these things, including death. And so the same can go for knee replacements or other types of surgeries. So there's risk to all things that are more invasive. If we're going to compare the safety of more regenerative based injection procedures, which we published, the Regenexx organization published a 10-year follow-up study on patients that underwent stem cell therapies for orthopedic conditions. The serious adverse event rate was 0.17 related to the procedure. We saw fusions are super high. We saw knee replacements are up to 16%. Even joint arthroscopy has a complication rate of up to 5%. Despite undergoing surgery, not everybody gets back to full function. And pain is often a common symptom post-surgery. So just things to consider. Again, sometimes it's the right choice, but if we can learn about all options available to treat our orthopedic problem, then we can have that conversation about what's the right choice based on the structure. And again, we'll get a little bit into that about how we start to determine if what we do is an option for patients. So where does Regenexx come into this? How do we play? What do we do? And when did Regenexx come about? So as I mentioned, I've been with the Regenexx network since 2015. Regenexx was started in 2005 in Colorado by Dr. Centeno. It's grown significantly. So it's a group of physicians and physician network that focuses specifically on orthopedic care, non-surgical orthopedic care, utilizing cellular-based therapies to help, again, maintain, preserve, and improve orthopedic tissue and pain. And so we have clinics all throughout the US, some international clinics. This is the only clinic here in the Las Vegas area. So historically, our approach has always been to have innovation, clinical research, track patients, use our information to help guide treatment decisions, and to publish. So the Regenexx organization publishes research every year. We actively track our patients in a registry to ensure that we're understanding the outcomes, the benefits, who's a candidate, who's not a candidate, what are success rates, so we can have that conversation. Again, education is a key to determining what's the best choice for you in your orthopedic treatment. And again, it's just really, if you think about it, it's just the evolution of medicine. As we learn more, we get more technology, we understand things more, then things evolve. There's, a phase where things are being used, more research, more awareness. And so it's just the natural evolution of medicine for orthopedic care. Again, these are minimally invasive. Everything we do is injection-based procedures. And essentially, the big key is here, we're using healing factors and components from your own body, such as stem cells, platelets, growth factors, and these are being delivered to the areas of injury or degeneration or inflammation or tissue overload or instability, with our goal to preserve tissue and again, reduce the exposure to the risk of surgery. And so the types of solutions and things that we're injecting are called orthobiologics. And just to understand the foundation of why these things can help, it's just really understanding the fact that we all know that we have the capacity and the internal hardware to heal. And we see that with when we injure or say a cut or something, you see skin heal. So you have bleeding, you have clot, you have healing of that skin. If you break a bone, you may need surgery to stabilize it, but it's your body that does the healing, not the surgery. And so understanding that there are certain cellular components involved with the initiation, activation of healing, and that sometimes we don't heal because of kind of a supply and demand mismatch or from trauma. So degeneration and osteoarthritis, tendon degeneration, which can lead to tears, can happen in tissue that's being overloaded over extended periods of time. So you go through a weakening phase, you lose blood supply, you get overwhelmed with chronic inflammation and destructive chemicals, which can cause pain and further destruction of that tissue. And so you start to have the supply and demand mismatch, and you're not getting the necessary nutrients to the area. And so we can try to supplement that with different cellular-based treatments, growth factors to help reestablish more of a balance and reduce the chemicals and the environment that's destructive to healing, and supply things that are rebuilding and more healthy for regrowth and improvement in tissue. And so there's cells that we can isolate from your own blood, from your own bone marrow. There's more research on third-party sources of cells that are still being explored and not quite yet approved in the US, but a lot of things that we can even extract from your own body to use for treatment, orthopedic care. One such thing we use is the platelet, and that's found in your blood. Platelets have many functions, of which they are the activators of healing. So when there's trauma, you bleed, platelets bind in the trauma site, they stop the bleeding, they release all these different growth factors to stimulate different components needed for healing. Cell growth, blood vessel growth, collagen production, all of these things are needed to help improve the signal for healing in tissues. So we tend to utilize this more for mild to moderate arthritis, tendonitis, bursitis, small partial tears and soft tissue. There are studies utilizing it for peripheral neuropathies, say in diabetic peripheral neuropathy, carpal tunnel syndrome, Those have been explored as well. There are other proteins within our blood that can be used to help combat arthritic inflammation, and this is called A2M. You can isolate it from the blood serum. It's a very strong anti-inflammatory, and can reduce swelling and cartilage breakdown, and so you can use it as more of a protectant to joint arthritic changes and inflammation. The thing that people hear a lot about are stem cells. We're specifically talking about mesenchymal stem cells. Other people call them medicinal signaling cells. So cells that are found within our bodies that can respond to injury, that can assist with different tissue healing. In the lab, these cells have the capacity to transform into different cells such as bone, nerve, cartilage, muscle. We tend to isolate these from a bone marrow aspiration. That's called bone marrow concentrate. The bone marrow concentrate contains mesenchymal stem cells. And again, these cells act as a way to rebalance that negative overloaded degenerative environment. They help maintain that local homeostasis, improve healing and maintenance of tissue. You can utilize these for more moderate to severe osteoarthritis, degenerative changes, a little bit larger tears in muscle, tendons, ligaments, or people that haven't responded to the PRP. It can be the next step in the treatment pathway before people progress on to other interventions. Just to look at the fact that there is data and research, some conditions more than others, just looking at an overview of orthopedic stem cell research going back to the 1990s. So there is different research out there. This is just the data out there specifically for bone marrow derived orthopedic use. Just looking at different studies out there. The yellow studies are ones that Regenexx has published. Also looking at platelet-rich plasma, randomized controlled trials, knees, hands, hip, shoulder, carpal tunnel, elbow, lumbar, low back, Achilles, ankle. So all of these include different studies where PRP was compared to some alternative control, with most studies showing that PRP was as effective or superior to the alternative. Some of them were compared to surgery, steroid, exercise, medications, steroids. So a lot of comparative studies out there. And again, we track our own patients in our registry. So we have our own internal data. We publish randomized controlled trials as well. And so we utilize all this information as a way to help educate patients. And so that leads me into the process that we have in the education. So compared to, say, your normal visit at your physician or orthopedic office, our new patient consultation is about an hour-long process. And the overall kind of process in trying to educate people on if these are options for them is we have our prediction process, our processing, and the delivery of these to help improve the overall success. And so if we just focus on the prediction process, this is just to highlight the fact that we focus 100% on orthopedic conditions involving all parts of the body, from spine, shoulder, elbow, hand, hip, knee, and foot and ankle. If there's a joint, we've probably injected it, a muscle, tendon, ligament that protects and surrounds the joints, we've treated those as well. And so our prediction process includes a few things. Our consultation, which I said was an hour long. Our registry, we're currently tracking about 80,000 patients or right around there that are actively being tracked in our treatment registry. And the research that's published internationally and through our own data. So our consultations are an hour long. We have to review and understand what's going on with you and your body. We have to look at the structure. So it's very important that we know what's going on structurally. We hear people go to clinics that don't even look and review the imaging. It's like, how do they know what they're treating? How can they really educate a patient on what their, treatment option is, what treatment's best for them, what's the overall candidacy and success rates for their specific condition. So we like to walk through and educate people on their imaging, the structural abnormalities, and how that may or may not relate to their symptoms. We perform a physical exam, and all of this, along with all of the other information from registry and research and all the stuff we understand, helps us develop a customized treatment plan and a candidacy status. Again, just highlighting our registry. We have patients, this is on our website, the regenexx.com website. It's on our website as well, where people can look at, okay, in general, these are just all comers, people for knees or ACL or spine or elbow or foot or hand or hip can see on average improvements in pain, joint pain, overall function over time. This is a little outdated. We're currently at about 18,000 knee outcome patients within the registry. We've also published as an organization lots of research, performed clinical studies. Again, these are all the things that help us educate patients on what the options are. And in the end, the goal of the new patient consultation is for a patient to understand all of their options, whether it's what we do, whether we think that surgery is the best thing and we can refer you on. Maybe you need physical therapy or other types of intervention. But regarding the regenerative type procedures, we can rate people as far as high or low responder. And this is determined through the overall evaluation process. Every part of the body is a little bit different as far as structural things that may or may not affect your candidacy. Once we decide that someone's a candidate and we're going to go forward with procedure, the processing of those cells that we discussed, bone marrow derived stem cells, platelet, growth factors, A2M, we have a flexible lab platform that allows us flexibility. We know that dosing matters, so you have to be able to supply the right dose for the right problem, the age of the patient. And since everybody's different, you have to be able to fluctuate that treatment based on the person and the condition. A lot of clinics out there have automated machines that are one size fits all approach that starts to limit their ability to customize a treatment for your specific problem. And so that can start to have an effect on the chance for success and the overall outcome. Our flexible lab platform includes manual processing. Again, we can customize concentrations of, say, platelets based on age, injury, location, tissue type. We can make all different types of products. If you had one joint that needed one type of intervention and another area that needed something else, we could do that all in the same setting. And we do have multiple lab patents for processing and isolation techniques. Once you have those products and those cells and those growth factors that you want to deliver to the appropriate position, you have to be able to be precise with where you're placing them to optimize the overall outcome and chance for success. Unlike what you may hear, stem cells or other cellular therapies don't just somehow magically end up in the right place. They are better delivered, and the outcomes are best when delivered precisely to the area of injury. And so in order to do that, you have to have the appropriate equipment, such as this picture shows an X-ray called fluoroscopy, to assess where the needle placement is. Again, this is an MRI showing the structural problems, which is a cartilage arthritic joint with a bony injury of the kneecap, and the corresponding procedure images showing precise placement of the different cellular products into those areas. Or for example, a shoulder, this is using X-ray, treating a labrum and a shoulder joint, ultrasound at the wrist, injecting platelet growth factors around the carpal tunnel nerve to help with carpal tunnel syndrome. So precision is key. It helps improve safety. It helps improve outcome, and important to consider when getting these types of treatments. And so we feel that these 3 steps help, create a difference in what our approach is compared to what we've seen other clinics' approaches are. Now, when undergoing these procedures, just a brief overview. Again, this webinar is more of a brief kind of overview, just to kind of plant the seed on kind of what we do and how we approach care. But the PRP approach was just a platelet approach we call SCP for super concentrated platelets, because we can concentrate them as high as we want and get as many as we want to deliver. But that's a 1-day procedure. It does include blood draw, processing, and injection. With any injection or treatment, because we're trying to enhance the overall body's response to the tissue, there's going to be some soreness for a couple days, some modified activity for a few days to a couple weeks. Some people need bracing, some people need physical therapy. We follow up every 4 to 6 weeks. If you track people long enough, there's always people that need more than one treatment to derive significant benefit. A lot of people can get improvement with one treatment. A lot of it gets down to what are you trying to treat? And again, we have all that conversation during the consultation, so you understand where you fit as far as potential limitations, those kind of things. The stem cell Regenexx process from bone marrow concentrate can be a little bit more involved, with 3 steps where we're trying to kind of create a pro-inflammatory healing response, followed by the stem cell treatment, followed by a PRP growth factor treatment to help feed that tissue. This tends to be more for higher level arthritic joints. Certain types of tears and other things, you won't necessarily undergo the 3-step process, but these are just different ways that we approach care. We do talk briefly here about the fact that, as we mentioned, not everybody is a candidate, not everybody is a good candidate. So we do have to understand that there can be limitations to these orthobiologic injection-based treatments. And so we have to understand what they can do and what they can't do. And we have to understand that FDA does regulate all human cellular tissues and products, HCTP regulation. This is beyond the scope of the talk, but there are very specific regulatory guidelines on what cells can be used from what source for orthopedic conditions. And so for that reason, we do not use umbilical cord products. They are technically not compliant through the FDA. Most of the tissues in the United States derived from placental umbilical cord products are dead tissues. They do not have live functional cells. We've tested many products in the lab to see if we could purify or grow mesenchymal stem cells from umbilical cord products. And we couldn't isolate any, not even one stem cell colony from those products. Outside the United States, that's different. There's different regulations on how they can kind of purify and expand those cells. We can talk more about that if people have questions on it. There's a lot less studies on those types of treatments compared to autologous treatments, which we can talk more about if you have questions on it. So at the moment, we're not utilizing umbilical cord tissue, secondary to compliance issues with FDA, issues in the United States, independent labs not being able to confirm actual live cells in those tissues. They're all dead tissue. And then the lack of human research. So we're not utilizing that at this time. We do have other things like pain laser and things that are non-interventional that can also help with different orthopedic tissues, pain, inflammation, healing. Not necessarily a big part of like the Regenexx approach, but something else that's used as an adjunct for trying to prevent the progression for medication use and to help with healing and orthopedic pain. Now I want to leave it open for questions to see what questions you guys have on anything that we discussed. Again, this is more of just a brief overview, planting the seed on who we are, how we, what we use, and how we go through the process of understanding what's going on with our patient's condition, the discussion and education on how we treat those things, the overall discussion on candidacy and success rates, and where we get that information from. Questions on, do you do x-rays and MRI in the office? The only modality we have for imaging in the office is ultrasound. So we can use diagnostic ultrasound for a lot of peripheral conditions of joints. It's not useful for spinal conditions. We can order x-rays, we can order MRI, but we don't have a diagnostic x-ray machine in the office, and we don't own an MRI, but we can order an MRI or x-ray for anybody if we feel it's needed. All spine conditions need MRI or CT scan. Some joint conditions need MRI, depending on the problem. Sometimes x-ray and ultrasound is enough. Just depends on what's going on. Are there age factors for seniors? They can be. This depends on the joint, depends on other medical comorbidities. For example, in knee arthritis, age does not play a role in the overall outcomes or success rate. So when we've looked at outcomes as a function of age, starting at 30 upwards through the 9th decade of life, so in the 90-year-olds, there was no decline in outcome based on just age as an independent variable. So that was not a factor. Hip arthritis has a little bit more of a factor with age, where you start to see some decline in the overall outcomes after 65. We don't see too much decline in spinal treatments until about after 85, where maybe people just need more treatments. One thing you do see is that in older individuals, for tendon or cartilage issues, you tend to need just higher concentrations. And so the fact that we have a flexible lab that can deliver higher dosing helps combat any decline in response with from aging. So we did a study that looked at growth rates for cartilage cells and tendon cells as a function of platelet dose. And as people aged, they had increased growth with increasing dose. So the growth increased with the increased dose of the platelet growth factors, whereas young patients, which was really like in their 20s, would plateau very early. So higher doses didn't create more growth, but in older individuals, higher growth factors created a linear growth pattern. So you just have to provide the right dose, and that can help offset any effect from age. So question, if we have MRIs, we should bring to the appointment. Yeah, it's important to bring imaging if you have it. We tend to recommend imaging within 12 months. If it's older than that, we can review it, and then based on symptoms, decide if we need to update it or not. Some people will send in their imaging ahead of time for review to see if the condition is something we feel we have options for that we can discuss or look into more. That's an option as well. We like to walk through the imaging in clinic so we can point out what we see and then how that may or may not relate to your symptoms. So we want people to feel educated on what their condition is, understand why we feel we can help or not help, and then that helps them feel better about their decision. Can two areas be treated in one visit? For example, bilateral elbow pain and bilateral knee arthritis. Yes, it does depend on, there can be a limit depending on the severity and what cells are needed. When you're using bone marrow derived stem cells, usually 2 large joints is the extent of what you can get and extract to have a high enough volume and concentration and dosing. PRP, you can treat more areas because you just have more platelets to go around. Having said that, if you're somewhat anemic or very small or petite, sometimes we have to limit the blood draw volume. So there can sometimes be a limit if we're having to treat a lot of structures at high dose and high volume. But in general, we can treat more than one area. So does insurance usually cover consultation and injections? Insurance does, if we're contracted with your insurance, it does cover consultations. Most PRP and stem cell bone marrow orthobiologic based injections are not covered by insurance for the most part. Regenexx is the only organization that has some coverage through specific employer-based plans. We have that are self-funded, so we have more than 2,000 companies across the US that cover Regenexx for their employees. So just like you would get coverage through any other medical procedure, but that's only specific to these employers. So you can always call our call center to see if where you work, if it's self-funded, has a contract with Regenexx, but your basic United, Medicare, Aetna plans don't tend to cover these types of procedures yet. But consultations can be covered through your insurance, and imaging that we order can be covered through your insurance, those kind of things. If I have x-rays of the problem area that were taken in the last 4 months, no. If you have x-rays within 4 months and there's been no new trauma, no new injury, then that's fine. We like to review those. If it's an extremity, we'll do ultrasound. If it seems like there's something deeper that we need to evaluate, for example, in knees, if we were concerned about a specific type of meniscus tear or ACL tear or a cartilage or bone injury, then sometimes we'll get MRI to look further into that to make sure that we're educating you the best we can regarding outcome and efficacy of the procedure. But you wouldn't really need new x-rays within 4 months. Medicare covers MRI. That's yes, for sure. So we can order imaging through your insurance pretty easily. That's usually not an issue. Some of them definitely need like prior authorizations and stuff, but Medicare doesn't need prior authorization. What's the success rate of patients who have had just one treatment for joint damage? How long before another treatment is needed? Well, that just depends on what the baseline severity is. So it's hard to give a specific, because if you have severe arthritis, for example, and if you're using PRP, the overall outcomes will be very different compared to bone marrow derived stem cells. If you have hip arthritis versus knee arthritis, the outcomes can be different. If you have a tendon tear that's small versus large, it will be different. So it's tricky to say. In general, if you have mild to moderate arthritis, so anywhere from grade 1 to grade 2 arthritis, the overall efficacy for PRP being helpful, which is the platelet base, is in that mid 80 to 90% of patients get better. The overall effect of that can be a couple years. Some people 3, 4, 5 years. Some people sit within that 1 to 2 year range. If this is a degenerative process, if it's a tear and it heals, that can last forever. If you have a tendon tear, that can last, and it heals up, that can last forever unless you re-tear it. But if we're talking about joint degeneration arthritis, you'll get a window of improvement, you'll get protection of your cartilage and preservation and longevity, but if you continue to use your body, you still create a little wear and tear. If you have, for example, bone on bone, grade 4 arthritis, for example, in your knee joint, and you use PRP, it tends to take 2 or 3 treatments, and the overall percentage of people that get improvements about 60% with an average duration of about 18 months. So it really depends on the severity of the underlying problem, what treatment you're looking at, and then that will determine success rate, longevity. So it really depends. Hopefully that helps. Will insurance cover the MRI? You do. Yeah, we don't have our own MRI, but we can order an MRI, and that can be covered through insurance. Some insurances still need prior authorization. I'm contracted with a lot of insurances. So we can get MRIs ordered through insurance. But again, some of them require prior authorizations. They can still be subject to your co-pays and deductibles and all those things. But we do that all the time for patients. Oh, the ultrasound. Yes. So yeah, the ultrasound can be covered through your insurance. It is. It's part of the consultation. If we're using it for an extremity and you don't have other imaging, then that can be billed through the insurance. And that's not something that tends to need authorization or anything like that. It's just kind of an extension of our evaluation and our physical exam, for example, just to see what's going on. Some people ask about safety. They're very safe. It's like I said, it's very safe. It's just an injection-based approach. But you're still poking into the body, right? So you have to be aware that there's still something going on. Most people do get a couple days of soreness and inflammation. Just depends on what condition we're treating. If you have to inject the meniscus, that can be uncomfortable for a little bit longer. If you have to inject someone's low back disc, for example, then that can be sometimes painful from 2 days to 2 weeks. Just depends on what you're treating, what needs to be injected, how much. Again, some people need bracing, some people need physical therapy. The repeat injection rate can again be dependent on what people's condition is. Low back, the repeat injection rate is probably 30%. Extremity-based stuff, if you're mild to moderate change, is maybe in the 10 to 15% range. So it just depends on what you're treating, really. They ask, are you awake? Are we awake for the injections? So it depends. We do have the option for sedation. So like twilight sedation. In office, we bring in nursing or a nurse anesthetist to come in and do that for us in the office. Most peripheral joint injections don't need sedation. So spinal conditions, sometimes people will choose to have some sedation. Bone marrow aspiration, some people choose to have sedation. We do use local anesthesia. So we do numb the local tissue around the joint. That helps with tolerance. But people do quite well as far as the procedural injections, but some of it depends on your anxiety, your fear, and then what needs to be treated, how many injections you need in one session, and then people may or may not choose to add in sedation. Because in the initial consultation, will you go over all the body parts that may need treating, or will there be separate appointments? It just depends on how many. Usually in an hour, we'll do about two. We can do like 2 body parts, 2 or 3, depending on if we have to do ultrasound on them. They can schedule longer consultations if you have many body parts to be seen for. If we start to get to 4 or 5 different body parts, then we'll probably have to split it up into two separate sessions. Again, depending on if you have imaging or you don't have imaging, do you need ultrasound on all the areas? Because then it starts to be a very lengthy process. And so we try to, when people schedule, understand what they want to be seen for, maybe prioritize the first 1 to 3 areas. And then if we feel that we need to look at other areas, if we have time, we do it. If we need to schedule a separate appointment, we can. So one way to get in touch with us is to call our call center and scheduling line here. They are good at getting you education information. If you have questions, if you have imaging you want to get to me, they can help facilitate finding a way for you to upload them or get the imaging to me. If you want kind of an MRI review ahead of time before scheduling a consultation to make sure it's something that has some level of option, even if it's kind of a limited option, sometimes we'll still discuss what those options are. But people will sometimes send in their imaging for us to review. So you can take advantage of that. They can get you scheduled for an in-person consultation. Again, consultations, if you were contracted with your insurance, we can bill through that. And so they can give you all that information. There's really no downside to come in and get seen. In all reality, you're probably just going to get better educated on what's going on. You'll be able to see structurally what's going on, have an idea of all available treatment options, because we try to at least give you an idea of what's available basically out there, including what we do and what we focus on, and then try to help direct you in the right way, based on your condition, success rate, options, ability to pursue these procedures or not, like that kind of stuff. So there's really no downside to it. Well, at the moment, I don't see any other questions. I appreciate the questions. Yeah, we will see you here in the clinic. Yeah, we look forward to seeing you guys. So have a good evening. Reach out if you have more questions. If not, come see us in the clinic, and we'll go from there. Have a good evening. Thank you for joining me tonight.